have a lot of things come their way when they receive a cancer diagnosis, and sometimes fertility is not always at the top of their list, understandably. But something that, later on down the line, they may think, oh, I wish I would have known about that, or things. So just kind of trying to let you know what we do here, what options are available for patients, and some special considerations and things like that. So, all right. I have no financial disclosures, unfortunately. So some objectives today, really, again, to discuss fertility preservation, really focusing on after receiving a cancer diagnosis, talk about the different treatment options that are available, maybe some of the risks or side effects of some of the treatments, the options that are available here in West Virginia, and specifically at WVU, and then kind of discuss what patients should expect during their consultation and treatment with us or potentially someone else. All right, so a quick, just little case presentation to kind of break the ice here. So we have a 31-year-old gravid-0 female who presents for discussion after recent cancer diagnosis. She actually has a 9-year history of infertility and was undergoing some ovulation induction medication treatments in Beckley. And there was some concerns during one of her visits for possible DVT-PE. She got a workup, and a CT scan revealed a mediastinal mass. Ultimately, her diagnosis was a stage 4A thymoma with mixed histological pattern. You guys probably all know better than myself really what that means with things, but her anticipated treatment regimen, she'd already had an excision of her mass. And she was being recommended for chemotherapy and radiation with an anticipated regimen of doxorubicin and cyclophosphamide with possible carboplatin. The exact treatment start time was still undetermined, but we were meeting with her because, again, she'd never been pregnant before and did desire some children. So this is, not an atypical consultation that we'll get. Probably the most common cancer diagnosis that will come to us is breast cancer. And we'll kind of talk about that and some of the unique challenges or unique situations that we'll think about with breast cancer. But, we can see patients with all kinds of different types of cancer diagnosis. Now I think, well, now what? What do we do with this patient? So first thing we think about is some considerations when they want to talk about fertility preservation or when a consult's placed. One of them is age. Are they prepubertal? Pubertal? Are they coming close to menopause? What is their reproductive age? What are their future fertility desires? Do they even want to have children in the future? What's their past reproductive history? What type of cancer do they have? What's the stage? What's their prognosis? We've had some consults for some patients who are unfortunately pretty sick, and their outlook, unfortunately, has not been very good. And so we have to think about the future prognosis and will they be alive in 3 or 5 years to even come back to use their stored reproductive tissue, or is pregnancy safe in the future? We think about their treatment regimen, kind of the short and long-term effects, both on their general overall health and then affecting the reproductive organs, their ovaries, their uterus, things like that. What time frame do we have to work with? Some of these diagnoses require more immediate treatment, and some we have a little bit of time where we might be able to get a fertility preservation cycle in. Our goal is always to do what's best for the patient, and if what we would do for fertility preservation would delay their treatment, and if that delay would adversely affect their treatment and potentially their long-term prognosis, then our interest is not in fertility preservation with that patient. We want them to have the best long-term survival chance as possible. We'll think about the cost to discuss with the patient what these therapies cost, because they just, with their cancer diagnosis, they're thinking about all the other medical expenses and treatment costs and things. And this is just another thing that adds about another $8,000 to $10,000 onto everything else they've just had to kind of get surprised with. And like I mentioned before, we think about the safety of a future pregnancy. How will this affect her reproductive health and just her overall health in general? Is carrying a pregnancy and getting pregnant in the future safe? So sometimes we may have to to get a consult with our maternal fetal medicine physicians and think about pregnancy down the line. And then we'll also talk about their other options, whether that's uh, donors, either eggs or embryos, having a gestational carrier, child adoption, things like that. So lots of stuff we'll consider and discuss with the patients during our consultation, or even when the consultation comes in. So one of the first things I think about when I look at treatment regimens is, okay, what's that going to do to the ovary? Because that's where our eggs come from, and that those chemotherapy cycles can sometimes be very damaging to the ovary and put patients in primary ovarian failure, and using their own eggs in the future won't become possible. So there are some regimens and some agents that have very low probability for ovarian damage, a few that are kind of unknown. There are some that have a probable association with ovarian damage, and some that are definitely associated with ovarian damage. And unfortunately, the more common ones like cyclophosphamide, doxorubicin, the platinums, are commonly used in many treatment paradigms, and those are ones that are probably or definitely associated with ovarian damage. And so we'll talk to the patients about that also, what the likelihood is of this affecting their ovary and their egg supply. A lot of this information and a good reference point is this practice committee document from the ASRM, which is our governing body in infertility. And it goes through fertility preservation in patients undergoing therapy or gonadectomy, kind of walks through each of the different areas, and it's a very good reference document. It's just recently updated a couple years ago, so it's got a lot of the current information with some of the newer preservation techniques and things. All right, so some indications for fertility preservation. Obviously, malignant conditions is one, and that's the initial reason why fertility preservation was developed and started. But we also think about non-malignant conditions. Sometimes patients will freeze for other medical conditions, endometriosis, adenomyosis, fibroids. Maybe they're having surgery to remove fibroids, and that's going to delay their ability to get pregnant maybe by 6 months or a year. And so they may preserve their fertility before that, kind of like a little back to the future. They can freeze time, so to speak. And then they also have elective fertility preservation, those that just want to delay childbearing for schooling or job promotion, job growth, things like that. That's becoming a lot more common nationally and worldwide to delay childbearing. We're going to focus a lot more just on the malignant indications today. So a few cancer statistics. So this data is from a couple years ago from the CDC. So in 2021, there were just under 1.8 million new cancer cases diagnosed in the United States, which is about 349 per 100,000 population. So if you look specifically at West Virginia, we're a little bit on the higher end of that. When you look at the map, we're around in the 470 to 510 per 100,000 population. Interesting, just right over the border in Virginia, they're much lower, but you can kind of see the states around us. Some have high cancer rates like we do, and some are lower. We see typically more breast cancer here in West Virginia, which I think probably bears true with just anecdotally what we see kind of come through our clinic for fertility preservation. A lot of breast cancer, unfortunately. And then probably the leukemias and non-Hodgkin's lymphoma are our next most common, even though they're less common on the graph here. So, all right. So now what? What options are there, and how do these options work? What's the best, or what may be right for the patient? So there's this great book, What to Expect When You're Expecting, which pregnant patients will get and read through, and it helps guide them through each stage of pregnancy. And it's a great resource for patients. You can even get books on fertility that kind of walks you through what to expect for fertility treatments. Unfortunately, there's not really any good how-to, what to expect books or manuals or anything out there on fertility preservation and reproduction after cancer. Most of the literature out there are textbooks designed for the providers for us to figure things out. This is kind of a newer part of what we do in reproductive medicine. We don't have good what to expect literature for patients. And so, of course, they go onto Google and everything and try to find out on their own. And just like anything else on the internet, what you find on the internet sometimes is variable in its accuracy and truth and things. So hopefully today will guide a little bit better on what options are out there. So one of the first things we think about when dealing with oncofertility is what are the requirements you need to have as a program for to be able to offer fertility preservation. The first thing we need is rapid access. You know, these patients a lot of the times don't have a lot of time to spend waiting, 4 months or 6 months or whatever to get in to a specialist. They need to be seen within a day or two. You need interdisciplinary teams and collaboration. And I think we've been building that up between the CRM and the Cancer Center, the AYA special interest group and things. Over the last few years, we've been developing those collaborations and teams, and I'll kind of go into that a little bit further later. You need a laboratory that does in vitro fertilization or can freeze tissue, freeze embryos, freeze sperm, do those things. And it's recommended you have counselors in a couple of different areas to help these patients through, to help them navigate, genetic counselors, financial counselors, mental health counselors to help them through, because these situations, these therapies and everything can take their toll physically, emotionally, and can also take their toll financially. So we have all those options available. All right, so meeting those program requirements here at WVU, again, rapid access, we do have that. Most of the time we can get patients seen within 24 to 48 hours if need to. We've gone over to see patients inpatients. Telemedicine has really helped be able to see patients rapidly. If we can't get over to Ruby, we can, over a lunch hour, we can set up a video visit, or if somebody is away from Morgantown, we can see these patients pretty quickly. And with 4 of us here at the center, one of us is usually available within a day or two to get these consults scheduled. We really do prioritize getting these patients seen. Again, I talked about our multidisciplinary team. So we have been improving that collaboration with the Cancer Center. Brittany Jarrett is one of our nurse practitioners who some of you may know. She used to work over at the Cancer Center. She's been a great resource helping us navigate, just sometimes knowing people and who to contact is great to help establish these collaborations and smooth discussions and just sometimes you just need to know who you need to know. Also, another shout out to Adrian Duckworth, who's been instrumental in helping with this collaboration, getting some things in Epic set up to where it's a question now in the intake. Do you want to know more about fertility preservation or getting pregnant in the future? And if they click yes, then it sends a referral to us automatically. So we're kind of help streamline that process so nobody gets overlooked, because for both patients and providers, there's a lot going on at this time, and it's easy to skip over things or not remember them. So we're trying to make things as checklist as possible. We do have an IVF laboratory that has all the capabilities that we would need, or most of the capabilities that we need for fertility preservation. And I say it's ready most of the time because we do twice yearly cleaning and updating of the lab. And so it does shut down for about 2 to 2.5 weeks in June. We just completed that time period. And then we shut down again middle of December for about 3 weeks. And then start back up right after the first of the year. So we have had one time in the 4 years I've been here where when the lab was down for its cleaning and maintenance, that we did have a cancer consult and the patient did want to freeze, and we just referred them up to UPMC. So we do have contacts and relationships of people we know at UPMC who can help us out in those situations too. So that patient was not left just, sorry, the lab's down, we can't do anything for you. We still were able to help them. And we do have counselors. So we have a financial counselor in our office here who's very great, works well with the patients and gets them all they need, can look into insurance requirements and options for payment plans or things. A lot of times we try to do what we can to take the financial burden off the patients from this standpoint. We do have a couple genetic counselors embedded through our department that will see these patients to talk about any genetic aspects of cancer. And we do have a social worker, and I think we just had another one start. So I think we have 2 now in our department who are in tune with what we do here and can offer good support for our patients. All right, so a few fertility preservation strategies that we'll go through. There's embryo cryopreservation, mature oocyte or egg cryopreservation, ovarian tissue cryopreservation, ovarian suppression, ovarian transposition. We'll go through each of those and some other options here. This is just a nice little graph that breaks down probably the 3 most common fertility preservation strategies of embryo cryopreservation, egg preservation, and ovarian tissue cryopreservation, and the different aspects to each, pros and cons. So this is a nice chart that we'll keep kind of in the back of our mind when we're thinking about different options and what may be best for patients, or when going through these things with patients. This is a nice chart to help them visualize things that are needed. So embryo cryopreservation is probably the most well-established, well-proven therapy for future reproductive success. It's been around for a number of years. We're probably bordering on 30 or 35 years now that some form of embryo cryopreservation has been available. We actually use the same protocol, and I'll say for normal IVF patients, those not undergoing a cancer diagnosis. So it's the same stimulation medications to hyperstimulate the ovary and produce as many eggs at a time as we safely can. It still involves the same egg retrieval procedure that we do here at the clinic. And then we'll get sperm from a male partner or a sperm source. And so that is one of the considerations, that it does require a committed male partner and sperm source. And sometimes if a patient doesn't have a partner or isn't ready to fertilize her eggs with a sperm source, that maybe this isn't the best option, because it does commit them to that sperm source. There's no going back once those eggs are fertilized. Another consideration is that patients have to be post-pubertal for this option. So this does not work well for our real young cancer patients, because they're not going through menarche and they're not going to bring up any of these mature eggs in their stimulation. So this is not an option for them. And then the time, we need about 2 to 3 weeks minimum for the stimulation and recovery period. So it will delay treatment starts for their cancer. And sometimes that is not a feasible option, again, given their prognosis. What's nice now is we've shown through some studies that luteal phase or random start protocols have demonstrated equal success compared to our normal conventional early follicular phase of the menstrual cycle starts. So we don't always have to wait a week or 2 or 3 for a patient's cycle to start so we can start their meds. We have protocols now that we can almost start any day of the week at any point in their menstrual cycle, and egg yields and embryo yields and success rates are showing that they're pretty equivalent. So that's very helpful. And again, this is probably the most well-established, well-proven therapy in terms of success, and success being defined as a live birth in the future. Our other therapies of egg cryopreservation and ovarian tissue cryopreservation are still a little bit newer. We just don't have the data that's as robust to show that it's as successful. So this still in our counseling, we still will tell patients that this offers at least statistically, the highest chance of future success for pregnancy is doing an embryo preservation. One step kind of below that is is egg cryopreservation. So very similar to embryo cryopreservation. It still can only be used in post-pubertal patients. Requires the same amount of time, 2 to 3 weeks, because we're doing the same protocol with stimulation and retrieval. But when we get the eggs out, we're not fertilizing them. We're just freezing those mature eggs. So the only thing we save is all the steps in the lab that happen later once the patient has actually already kind of gone back to their cancer treatment. So in general, you need more eggs cryopreserved than embryos to achieve the same number of live births, just because not all the eggs will survive the thaw process. They may not all fertilize or develop into normal embryos. So you just need a greater number of eggs to begin with. And so sometimes that requires us to stimulate the ovary a little bit more aggressively to try to get those numbers. And you'll see here in a little bit when we go over like the side effects and risks, the risks of being more aggressive with your stimulation and causing ovarian hyperstimulation syndrome and maybe things that actually delay their therapies even more. So there's always a balance that we're trying to have between getting the best number of eggs, the highest number of eggs to give them the highest chance of success in the future, with not, first principles, do no harm. We don't want to make them sicker or delay their treatment in any way. So this just shows the different start protocols that we have now. Kind of on the left side of that figure, these are our conventional starts that will happen usually after a period in withdrawal bleeding, kind of in the early follicular phase. But now we have these late follicular or luteal phase starts, or even just random start protocols that we'll use. And again, have shown good success rates with pretty equivalent egg and embryo yields compared to conventional protocols. So, all right, so in vitro egg maturation, or IVM. So we collect immature eggs. This is usually at the geminal vesicle, or what we call M1 or meiosis 1 stage. So these are typically eggs that are not developmentally far enough along that they can be fertilized. But now there are techniques that are still in research, still experimental, of maturing these eggs outside the body in the lab, in vitro. Still has to happen under a research protocol. It has not been taken off the experimental designation list yet, just because the outcomes, we're still not sure. There have been some children born from this strategy. I think about 100 and I'm trying to remember the numbers. It's under 100 patients worldwide still that have been had children after this oocyte maturation process. So still early in development, still lots of different protocols and techniques and methods that still have to be fine-tuned and worked out. We have small numbers, so we really don't know if it has much lower success rates or not. This is not something that right now we have the capability of doing here at WVU with the protocols and the different techniques and some of the technology things that we need here. We just don't have those things in the lab yet. That's probably one of the things down the line that we'll look at trying to do, especially if it comes out of an experimental designation. But right now, we don't have any plans to submit a protocol or an IRB for this therapy yet. So,
Dr. Heitman, can I ask a question at this point? Because this actually came up last week. The Mountains of Hope Cancer Coalition has a quality of life subcommittee. And this particular topic came up in last week's meeting. So if there's no protocols or plans for having IRB for something like that here, where would those patients would those patients be likely referred to?
Yeah, I know Pittsburgh has an ovarian tissue cryopreservation. I'm not sure if that includes this in vitro maturation protocol. I'd actually have to look up and see if I could figure out what centers are running these IVM protocols under research protocol.
Okay, thank you.
Yeah, my guess, if I had to guess, I would say at least Northwestern in Chicago would, because they have one of the biggest oncofertility programs, and they're one of the pioneers in a lot of these techniques. So I'm sure Teresa Woodruff at Northwestern probably has a protocol, and maybe even the Cleveland Clinic, because they're pretty big now into oncofertility. So
Thank you.
Could I also ask about timing and how, you know, how far from the diagnosis and then even a round of chemotherapy, does that just shut it down and you wouldn't even try? Or, and I'm not speaking about the in vitro maturation necessarily, but, sometimes you get a patient in and they're so sick and you've got, especially like with lymphoma or leukemia, and you've got to get something in
yeah,
or they'll die. But they also are saying, oh my gosh, they're AYA and they really want to have, fertility preservation as well.
yeah. We will definitely still see them in consult and look at their situation, and it's not always a deal breaker if they've had a round or a treatment cycle of chemotherapy. It really depends on how they respond, what they got, and age plays the biggest factor. The younger they are, the better, because they're more apt to bounce back, so to speak, have their ovarian function return. So I always tell them that too. If you're 16 and you're going through this, you actually have pretty good odds that your ovarian function will return over the next 20 to 30 years at some point.
Thank you.
So. And then ovarian tissue cryopreservation is no longer considered experimental. This is the only method for fertility preservation in pre-pubertal girls. It is an alternative to not delaying treatment for those that are post-pubertal also. So this is something that is on our list to add to our fertility preservation services here, hopefully within the next year or two. We want to meet with some of the centers that are doing this well and talk with them about their protocols and really get a protocol and a system established here that we could start offering some ovarian tissue cryopreservation for our patients. Theoretically, this preserves thousands of eggs for the future, and then you can transplant that ovarian tissue back into the pelvis. I've seen it placed back in the forearm, different places that you can then re-stimulate that ovarian tissue to take those follicles and get mature eggs from them. It's a little less proven in terms of that transplanted ovarian tissue in terms of how it functions well from a hormonal standpoint, in terms of providing regular hormonal support for these patients. That's not showing as much promise long term as maybe the reproductive aspect from that ovarian tissue. So, and there's about 130 live births worldwide that have happened now after ovarian tissue cryopreservation and reimplantation. So, what this therapy and technique has done over the last decade and how much it's grown and advanced has been really, really good, really is outstanding. But still is developing, different talks of whether you need to remove the whole ovary, whether you can take cortical strips from the ovary, whether you do wedge resections, a lot of different opinions and variations in what is actually frozen. But fortunately, all those options are showing good promise as that tissue is being used again in the future. So this is on my short list of what's the next step for our crowd or for our fertility preservation services here. So I'd like to get this up and going. But with everything, you just need time and money, right? All right. And then what if none of those options are going to be possible, either financially or just the timeline or whatever? There is an option for ovarian suppression. This uses GnRH analogs. Most commonly, we'll use agonist medications like Lupron. We can use antagonist medications. They just are a lot more expensive. They're a daily injection instead of a monthly or 3-month depot injection. Studies are mixed in its ultimate success for preservation of of eggs and future fertility. Depending on who you ask in the field, you'll get some pretty controversial replies and opinions with its effect. It is stated that it probably shouldn't be the sole method of fertility preservation, if at all possible. If a patient can do one of these other methods, then that's preferred. We will always offer it, counsel the patients that it may or may not be successful. My personal thought on it is there's probably not a lot of harm to it. The side effects that they'll get from Lupron, sometimes they don't notice because the side effects from their therapies, their chemo and things like that, and it may provide a benefit to them. So I tell them, at worst, that you don't get anything out of it, but you probably haven't burned any bridges, you probably haven't lost anything. The fertility and the reproductive aspect aside, there are some non-fertility benefits in terms of menstrual suppression, not having heavy periods and bleeding a bunch when they're already going to, be anemic or neutropenic or all these different things. There is some benefits to shutting off that menstrual cycle while they're going through chemo, radiation, all these other things. So I'll tell them, even if we only gain a benefit from that aspect, we're helping your overall just quality of life during the treatments. And we've been very successful working with the Cancer Center in coordinating getting these patients this medication either through our clinic or as part of their treatment regimen. So that's been something that's been ongoing for a number of years. Other options, less common, somebody's having pelvic radiation. We can do ovarian transposition, where we'll kind of move the ovaries up out of the pelvis a little bit, tack them up on the sidewall a little bit more, maybe get them as far away from that radiation field as possible. Sometimes they can do different shielding techniques and things, but again, we want their primary therapy to be as successful as possible. So we don't want the ovaries being in the way or things like that to determine, oh, well, we'll just change the route. We still want their primary therapy to take precedence. And then sometimes conservative surgical and treatment approaches. So if someone has a cervical cancer, a low-grade endometrial cancer, taking out their uterus, but maybe leaving their ovaries for the time being. That way they can at least get their own eggs out in the future, use a gestational carrier, and then once they're done, they can have their completion surgery with their oophorectomy at the end. If that would be acceptable, sometimes that is an option too. So we've done that a few times. All right, so what are some side effects and risks? Obviously, I've talked a little bit before about just the delay in potential treatments, and we don't want anything we do to delay their cancer treatments, and especially if that adversely affects their prognosis. The biggest thing we worry about from our stimulation is hyperstimulation, which is a syndrome that can last for a week or two afterwards, and patients can get pretty sick from it. They can get some electrolyte imbalances. They get very bloated. They get some ascites. They can get DVTs, PEs. Sometimes they have to be admitted to the ICU. Usually it's self-limited, but again, that would just delay something that we thought might only be a 2 or 3 week delay. Now it's a 5 or 6 week delay overall. So we're really cognizant of that hyperstimulation syndrome. Sometimes they'll get a poor response. There are some studies that show, these cancer patients, that physiologically, they don't always act normal because they've got an abnormal process going on in their body. They may not respond as well as we would have typically thought. And typically, they're only going to get one chance to preserve. Very rarely can we say, oh, we want to do this 2 or 3 times. We're not going to get that. It's kind of a one-shot deal. And so you really have to balance trying to get the most out of that one shot with the risk and the side effects of hyperstimulation and delaying treatment. So sometimes it can be a tricky balance. And then there's just the risk and side effects of taking daily injections, multiple daily injections. There are some low risks with their retrieval, bleeding, infection, things like that. So we, obviously wouldn't want to have them get a vaginal or pelvic infection right before they're about to start some other bigger therapies. So we always think about that.
Is your team the team to consult if you have a patient who's already pregnant when they're diagnosed with their cancer?
Probably the maternal fetal medicine, the high risk pregnancy doctors would
Okay,
be the ones that would handle it at that point. So Dr. Broncasio, Dr. Cummings, that
gotcha.
team. Yeah.
Thank
So a
you.
couple specific cancer populations and maybe some considerations. So breast cancer patients, especially those with BRCA, we always think about their estrogen receptor. Was it positive? Is it negative? Um, with the hyperstimulation process, we're going to make their estradiol levels go up 10, 15, 20 times normal. And there is the thought, well, is that going to feed then, especially these estrogen receptor positive breast cancers? Are we going to make that tumor grow rapidly in the intervening 2 to 3 weeks? Or is there any microscopic disease that we're going to feed with our therapies? A lot of our new protocols, we can use antagonist suppression, we can use letrozole and do some things to help drive these estradiol levels down during the stim, and then really drive them down after we're done with the retrieval to help with that. We think about pre-implantation genetic testing for those that may have a genetic mutation, talk to them about what are the risks of passing that mutation down to future children. This is where genetic counselors play a big role in helping us with that, but we have options that they can test their embryos for those mutations. And then ovarian tissue cryopreservation is not something that's recommended in the BRCA patients because of their risk of ovarian cancer in the future. So that's not something that we would offer them as a therapy, as a preservation strategy. With just general GYN cancers, again, that's going to be like your cervical cancers and your uterine cancers, fallopian tube cancers. Most of those treatments require hysterectomy as part of their treatment. So we think about talking to patients about having a gestational carrier and what that involves with that third-party reproduction and extra requirements, FDA requirements that we have to do and things like that. When we think about the hematologic malignancies, often these patients are very, very ill, like Dr. Lacombe was saying. Sometimes you got to get treatment started right because these patients are sick. They may not be eligible for fertility preservation. Has not been a lot of ovarian tissue cryopreservation in this subpopulation, so we don't know the true risk of reseeding a malignancy by transferring those ovaries back into the pelvis in the future. We don't know if they harbor microscopic disease in there or not. Pregnancy outcomes for embryos exposed to chemo are really unknown. So this goes back to Lori's question earlier too about if they've had a round of chemo before. We will still evaluate them. We will still see if fertility preservation is an option, and then just counsel them. We don't know what that exposure of your ovaries and those eggs to chemo are. There is some animal data that demonstrates there's an increased risk of miscarriage and birth defects, but we don't have any human data at this point, or at least not enough to really make any meaningful interpretations to counsel patients on their risk. And then children and adolescents. One of the biggest considerations we have here is we just don't have the facilities to offer them ovarian tissue cryopreservation. So these are patients that we will send up to UPMC because they have a very good ovarian tissue cryopreservation program that they've started over the last number of years. With Julie Rios is the one who kind of heads that, and she's really taken an interest in this and has a very good program up there. Sometimes, with children and adolescents, this is a difficult subject to talk with them about and their families. You're talking to a 7-year-old or an 8-year-old. Hey, do you want kids in the future? Well, like, I don't know. I was just hoping to go play with my friends at the park tomorrow. Like it's not even something that's on their radar. So trying to talk with them about that can be very difficult. And obviously with families and parents, this is a very emotional, difficult time. And it's just sometimes a very hard subject to broach. So again, many of these children may need in vitro maturation or ovarian tissue cryopreservation. So we are limited in what we can offer them here at this time. All right, we've talked a lot about female fertility preservation and being an OBGYN by training, that's where we always think, but there's a second part to this So the equation, what about male fertility preservation? So the standard, probably not, probably. It is really the first line. It's just sperm cryopreservation. This is, we can get a sperm sample via masturbation and freeze aliquots of sperm. That's easy. That's been proven. That's been done for decades upon decades. We can even do that after chemo has started, because the sperm production cycle takes 3 months. The sperm that we would get from ejaculation was made 3 months ago. So if chemo has been started, a day or two or even a week prior, the sperm that we would get is probably going to be okay. It's been sitting in the testicle, kind of in the epididymis, waiting to be ejaculated. It may not have the same exposure risk as that sperm that's in the testicle itself and the seminiferous tubules and things that's being developed and processed and being made. The advantages of sperm cryopreservation is it can happen multiple times. We can get collections back to back to back to back days, sometimes even collections multiple times in a day if needed. It's a little bit different than getting eggs to stimulate, which happens on a monthly cycle, right? So it's much easier to get sperm. Usually we'll have a urologic consultation with these guys too. We have the ability to collect here at the CRM if the guy is able to, or we've also had collections at the hospital, whether that's collection by the patient in their room. Sometimes these patients are going to the OR and urology is already doing a procedure and they can do a surgical extraction, with a TESI procedure, sperm testicular microdissection or something like that. So sometimes we'll go over and get sperm during those surgical cases. Just requires a little bit more coordination on those days, but our lab folks very easily can go over to the hospital, and sperm is much easier to transport in media and keep at the appropriate environmental conditions than eggs are. Okay. And something that's kind of come up new now is a system called this Protex cups. This is a collection cup that has media in it and helps regulate temperature and things. And sperm can be in these things for 24 to 48 hours. So this could be something I can see in the future, even in the next, weeks or months, that helps us change protocols and offers a lot more flexibility for inpatients or people who need to collect at home or, things like that helps free up some of that coordination difficulties that we may have sometimes.
And Dr. Heitman, there is a question in the chat
Okay.
cryopreservation. The question is, how long can cryopreservation be utilized before there is an impact on viability?
Okay. At this point, eggs, embryos, ovarian tissue, those sort of things can be cryopreserved and frozen indefinitely. So there's not really a shelf life on any of that material. We will store those materials here for up to 5 years in our clinic, in our storage systems. And then at that point, we will move them, coordinate with the patient to move them to off-site, like long-term storage facilities. But patients will come back 10 years, 15 years later to use embryos or eggs, sperm in the future. So it can be stored indefinitely with the new freezing techniques. That's a great question. Other options, again, cryopreservation of surgically extracted sperm. So coordination with urology for any surgical procedures that's needed. GnRH analog suppression, so again, using an antagonist or agonists in males hasn't shown a benefit at all, and it's not actually recommended to use Lupron or anything in males. For some reason, it doesn't quite work the same as maybe it would for females. And then testicular tissue cryopreservation, very similar to in females, the only method for prepubertal individuals. Special consideration for these individuals, if it is testicular cancer, there's questions of, do you really want to freeze that cancerous tissue and what options do you have? So fortunately, that's not a common occurrence for us here, but there are options potentially for those individuals. Okay. So this is the Center for Reproductive Medicine. We're located over here on Pineview Drive, just across the street from the White Birch Tower. So currently, we operate, or we have the top floor of this building. This is where all our consultation rooms and our IVF laboratory and everything are. So it's a nice building. It's away from the hospital. It doesn't look like a medical building. So a lot of patients will come here and nobody really knows why they're there. So they like that privacy and anonymity with things. So this is our team. It's myself as an REI, Dr. Rowans, an OBGYN that has an infertility focus in his practice, has been here for a number of years. Brittany Jarrett, who I mentioned, came over to us about 1.5 years ago as one of our nurse practitioners. Holly Beck has been a nurse with us for 6-7 years, and then recently in January, we hired her after she got her nurse practitioner degree. So she's got a lot of experience with our patients. Dr. Clemmer is our lead embryologist. He's our lab director. And then Dr. Chen is another one of our embryologists. So they're the ones that handle all the laboratory IVF stuff. So it's a great team that works well together and able to offer a lot to our patients. So what can we do for you or your patients? We can get your patients seen really quickly as we need to, so that's good. Currently, we can offer embryo cryopreservation, egg preservation, and then coordination with GnRH analog suppression, 3 main therapies, along with sperm cryopreservation. So what to expect with a consult? What can patients expect when they come see us? We can do their consultations in person at the CRM or via telemedicine. Very easy to do. They can expect that we'll get a pretty thorough history, go through a lot of their reproductive history, their cancer history and diagnosis and things. We'll talk to them about their future fertility desires, but we'll also go over their past reproductive history. We'll discuss all the different fertility preservation options, given all the other considerations that I mentioned earlier. We can provide them with some financial counseling. If they're in the clinic here, sometimes we'll just walk them across the hallway to where Dawn, our financial counselor, sits, and we'll have them sit down at the same time and kind of go over all the financial aspects of things. We can help with behavioral health counseling as needed. We have easy access to those folks, easy to place a consult or send an email behind the scenes and help get them the resources and help that they need. And then coordination with the oncology team over the plan of care. So we usually try to follow up with their team and say, hey, here's what we thought. We have it set up so our consultation note should get automatically sent via MyChart, via Epic to their care team so they can kind of see our recommendations. So, all right. I think we have a few minutes. I seem to talk a little bit longer than I had planned, but if there's any questions or discussion, what I'll do is I'll stop sharing the screen here and happy to take any comments or questions or patient situations or anything.
Can you talk a little more about how you use behavioral health specifically as a psychologist attending this? There's some obvious scenarios I can think of, but I wonder if, like, for example, if evaluations would ever be utilized to determine a person's candidacy for any treatment in any particular scope, similar to like a bariatric surgery assessment or anything along those lines. Is it typically just an emotional reaction and sending people to kind of address depression, anxiety, or are there other ways you utilize behavioral health?
Yeah, most commonly, like you mentioned, it is to help with the just kind of the emotional toll that these therapies alone take. A cancer diagnosis aside, we have a lot of patients that seek out just support because these infertility and these therapies itself is just so emotionally and mentally draining on people. We haven't necessarily used the evaluations to determine candidacy for this. I can't say that we wouldn't ever do that, but I think a patient have to be pretty significantly like a potential threat to themselves or just not a good situation. I've had situations in the past where we've had patients who have been suicidal and then the next month want to come in and get pregnant. Like, well, we might need to make sure that you're safe before we do that. And have run into some roadblocks, not necessarily here at WVU, but at my prior institution, where they said, well, that you can't make that decision. And I was like, well, I think I can. But unfortunately, that doesn't come up a lot.
You had mentioned about, having a financial counselor there. What is typically general average cost for these type of procedures that patients would be looking at having to cover?
Yeah. Ballpark average, we'll tell patients about $10,000. Usually, I think it's about 7,000 when you take a look at just all the lab and like the technology, the retrieval and the ultrasounds and things like that. And then most of the time, meds run about $3,000 to $4,000 with these stimulation medications. We will help patients look at different, whether it's like Live Strong, EMD Serono has a compassionate care. I think it's called the Heartbeat program, that patients can qualify for discounted meds, sometimes up to 75 or 80%. Again, Livestrong is a good one. Sometimes our other pharmacies that we use a lot will offer discounts to some of our cancer patients. I've looked into some of the programs that can provide medications for patients for free or through the pharmacy at a much decreased cost. And just the way our clinic is structured through the WV medicine system, we're not eligible for that program the way the clinic designation is, which is unfortunate because we could really help patients cut some of that cost significantly.
Does that cost just include the retrieval or like the storage fee? And then what is the overall cost for, implantation or,
Yeah,
that
that would just
overall?
include the initial stimulation, the monitoring, the retrieval, any lab culture fees, freezing fees. It includes the first year of storage in it. And then after that, it's just a yearly annual fee for the storage, which is like $500 a year for the whole year. And then when they come back to try to get pregnant, if they have embryos frozen, then an embryo transfer cycle, I think, is about $5,000. That includes pretty much all the meds and the monitoring, the transfer and everything. Little bit more if it's just frozen eggs, because we have to thaw and then do the insemination and lab culture fees. So their initial cost would be lower, but they're just deferring those lab fees until later. So
We're coming up on time. Any other last questions for Dr. Heitman?
I'm curious, if you lose contact with somebody at the time where eggs are being stored, what's your process for deciding what to do at that point in time?
yeah, so we will try multiple times to contact patients through multiple different methods to try to contact them. We'll sometimes even get different areas of the hospital or registration or patient services or somebody to help us out also. Try to contact patients. After 5 years, these reproductive tissues are then considered abandoned, and it kind of turns over custody to the clinic. Although I think any of us, especially Dr. Clemmer, you start to get real hesitant when you start making those decisions because you never really know how protected legally you are at that point. Something could always happen, and none of us want to get in trouble for discarding reproductive tissue for somebody's. So we try everything possible to get a hold of patients.
Okay. Just as a reminder, I know we had some folks who came on a little bit after we got started. If this is your first time attending one of our ECHO sessions and you would like to get CME or nursing credit for your participation today, Jenny just put in the chat a link to a registration for the CME office that is specific to our ECHO. So please fill that out so we can make sure that we get that turned in for you. I wanted to thank Dr. Heitman, for his time and having a discussion with us today, and for all of you for participating. Our next session next month is going to be on August 27th, and the topic is going to be on sexual health and cancer. So wanted to thank you all and hope you have a good day.
Thank you all.